We're all set.
Steve, everybody's admitted, or should we wait maybe 30 seconds?
I mean, we have 56 people in now. I'm sure they'll cycle in over the next few minutes.
Perfect. All right, let's get started. So I'd like to thank everyone for joining us. As you know, this is our second virtual ASES Journal Club. We are honored and privileged to have a phenomenal panel today, experts on the rotator cuff and all the sort of variations around the rotator cuff. So Dr. Savoy, Gettleman, and McDonald, I know many of you are very familiar with all their contributions that they've had, but we are also lucky enough to be joined by many of the authors on these articles that we have sent out. So Dr. Navizer and Flato will be discussing theirs, Dr. Jane, as well as Dr. Higgins, and joining Dr. McDonald will be Dr. Labner. So thank you very much for joining. We look forward to these discussions. Just a brief mention, Chris Clifton and I would like to invite anybody that had questions to direct to the chat or the question and answer session. Chris is going to be sort of manning this, and will be answering, or as many as he can, or directing to the panels as appropriate. And we also want to give a big thank you to Stryker and Zimmer Biomet for sponsoring this journal club. And Steve, I believe you have a video for us to play. Awesome. Thank you very much. So I guess without further ado, why don't we get into the discussions and kind of get this going. So the first article that we're going to be talking about, of those that we sent out, is Dr. Labner and McDonald's multi-center randomized control trial on single versus double row fixation. This is sort of our nice kickoff to this, as this is a popular topic to sort of discuss at many meetings. So this is a multi-center randomized control trial looking at single versus double row fixation, 90 patients, 48 single row, 42 double row. They did exclude acute tears. You can see table 1, they had very similar demographics between groups. Figure 1 showed how the double and single row were performed both with tied fixation. And then table 2 shows the very similar outcomes between the two groups at 0, 3, 6, 12, and 24 months. Ultimately, there weren't any differences in the clinical outcome measures looked at, but when you did look at the MRI and the ultrasound 12 months, the double had a higher healing rate of 78% versus 67%. And this held up in the multivariate adjusted odds ratio model. Overall, though, this is a phenomenal study. As you can imagine, level 1, multi-center, really kind of helps support clinically. Single versus double rows is a bit of a dealer's choice. Did sort of confirm some of these other clinical trials showing these differences, but it also did add some intrigue about healing rates. And, you know, ultrasound and MRI, MRI demonstrated healing rates at 1 year. And, you know, they did publish a follow-up study in 2017 for those that are interested on a cost-effective approach, given these differences in healing rates. And did sort of approach, or at least in this cost-effective analysis, suggests that potentially double row is more cost-effective than single row, despite the initial surgical costs. If you have improved re-tear rates, potentially have improved qualities. So sort of to start at this discussion, Dr. Labner, can you talk to us about what should you learn from this study, at least about your repair technique? What technique do you currently use, and kind of what you took away from this amazing contribution to our
Thanks, Eric. So that's a very nice summary. So for me, this really, as we went through the analysis and looked at the data critically, I think the biggest thing for me was that it put me firmly into the double row group. So double row is what I used ever since we completed the study and then the analyses. In fact, I tend to link the medial and lateral rows now. I'm into the transosseous equivalent, but double row was really the takeaway from the study. And I think what was interesting, so there are a few points. One was that although there were no functional differences in the primary or the secondary outcome measures in terms of the function, we did find, as you mentioned, a significant, not statistically significant, but what I think was a clinically important difference in the healing rates. And that highlighted for me the importance of using, and as a reader of these papers as an end user, the importance of looking not only at the primary outcome measure, but some of the secondary outcome measures as well. And I think the reason that so when we looked at the functional outcomes between the healed and the non-healed groups, the work scores were not significantly different, and neither, interestingly, were the ASES scores, but the constant scores were. And the reason for that, as you can probably guess, is that the constant score includes an objective measure of abduction strength. And so when we looked a bit more critically at the constant and the reasons for the difference, it really came down to strength. So I think the take-home message is that if the goal for us as surgeons is to achieve healing, we did show what I think is a clinically important difference, although we weren't quite powered to show a statistical difference between the two groups. Now, the second point is that Pete and I recently conducted a 10-year follow-up study on this same cohort. And we managed to get 85% of the cohort back in terms of the primary outcome. And the findings were quite interesting. There were two interesting things that came out of this analysis. So this is now, it's in press, it's not published yet. So what the 10-year study shows is that there was a significant difference in the primary outcome measure in the work between single and double row in favor of double row. So the double row scores were 79 versus 72 for the single row. So a 7-point difference, statistically significant. Whether it meets the minimum MCID, the minimum clinically important difference, I guess is debatable. The second interesting thing was that when we looked at the trajectory of patients, so the functional scores from baseline to 2 years to 10 years, when we looked at the 2-year to 10-year data, what we found was that the double row group tended to maintain their scores almost perfectly when we look at the primary outcome, whereas the single row group had a significant decline. It was just over 11 points in the work score, almost 12. We also saw that in the ASES. So there was a drop in the single row scores, whereas the double row scores were better maintained. Still, there was a small drop, non-significant in the double row, but there was a statistically significant drop in the single row group. And then finally, when we looked at the constant scores, there was a drop in both single and double in the constant scores, interestingly. The last point I wanted to make was you mentioned healing, and of course that's, I think, what the crux of a lot of this is about. So the Canadian Shoulder and Elbow Society, the CSES, recently completed a systematic review on single versus double in preparation for a position statement that we're looking at. We only included randomized controlled trials, so 11 studies, almost 400 patients. And the relative risk of re-tear for single versus double was 1.56. So what that means is that there's a 56% higher chance of non-healing in the single row versus double row fixation. So just to frame that, what it means is that if, for example, if in your population you have a 20% re-tear for double row, that would translate to an expected or predicted 31% non-healing rate for single row, according to this pooled data, which translates into a number needed to treat of 12. In other words, if you treat 12 patients with double row, you're now saving one, you're now allowing one to heal extra in that single, compared with single row. So number needed to treat, one would be perfect, right? A perfect scenario. Every patient you treat has a change in outcome. A lot of the common treatments in medicine, strong number needed to be 5, but some are in the double digits, like hypertension in a diabetic patient to prevent death is 15, just to kind of put it into context. So 12 is not so strong, but it is present, and it is, I think it's important.
That's fantastic. That's awesome. Dr. McDonald, do you want to either add to that? You know, how are you currently fixing, I guess, most of your rotator cuffs? tears and kind of anything you would want to add on to what Dr. Lautner said?
Well, what I learned from this study is that Peter Lappner is a really smart guy, and I just kind of followed in his footsteps. He set up a really good study, and we've done a few studies together. And as you heard, that he's really good at analyzing these things. So I think this was a good study. You got to put it in perspective. It's 2012, so a lot's changed since then. For example, the technique that we used was knot tying, and now my preferred technique would be a knotless crossover or a speed bridge type technique, which I think is an advance in terms of biomechanical strength of the repair and pressure on the footprint and whatever. Enhanced healing probably is better. So, and the other potential criticism of this study, well, you can always have more numbers. Numbers were kind of moderate, but the other potential criticism is there wasn't a huge difference in number of anchors between the single row and the double row. It was 1 versus 2 on average. So you'd like to see a bigger difference in the number of anchors in an ideal study if we were repeating that today. So I think in terms of techniques have evolved. We're probably all doing a knotless technique now. And I think probably a modern study would show an even bigger difference than this study did.
Oh, that's fantastic. All right,
Just
so
to
Dr.
remind
Gelman,
everyone, please put your questions in the Q&A, and we'll be happy to answer them as we go along.
fantastic. All right, so Dr. Gelman, can I get you to chime in on your thoughts on their findings and kind of your approach to when you use single row and kind of your thoughts on potential differences in this study versus potentially not, depending on how you interpret it?
Sure. So thanks. It's an honor to participate and be part of this panel. And it's nice to be the single row guy in a world of double row enthusiasts. And so a couple of things. First of all, I want to congratulate Dr. Lappner and McDonald in their paper. I quote it all the time. I think the fact that they really showed, no clinically significant difference has been something that I have used in a lot of my presentations. And I think what we need to really boil down to for today is how the double row was performed in this paper. And if you go back to 2012, it's pretty clear what they said is the comparison was their lateral row was the same for both cases. So if they did a single row repair, they used double loaded anchors on the lateral aspect of the footprint. If they did a double row repair, they still did a lateral row with double loaded anchors on the lateral aspect of the footprint. So in my mind, and this is something that Dr. Snyder and I have spent a lot of time on, you're pulling that rotator cuff all the way over to the lateral aspect of the footprint. Whereas we have been, very vocal about fixing the rotator cuff kind of what we call in situ. We're not under tensioning it, but we're trying to get the rotator cuff repaired just off the lateral margin of the articular cartilage where you have the best bone, and then going ahead with triple loaded anchors, not double loaded, because we know that we get 100% more strength to gap formation and resistance from Alan Barber's work, and fixing the rotator cuff just off the articular cartilage margin. What we're seeing with a lot of the systematic reviews that go back to exactly what Dr. Lappner just talked about, they're only using these level 1 or level 2 comparative studies. And almost every paper in the literature that meets that level of standard is looking at single row repairs that were done using double loaded anchors on the lateral aspect of the tuberosity. Bob Burks's paper is the same thing. Frichetti's paper is the same thing. So all of the single row data that has been compared to in most of these systematic reviews is not using what we ideally prefer as our single row technique, being triple loaded anchors just off the articular cartilage margin, microfracturing the tuberosity, creating a crimson duvet. If you compare the results of this paper to our most recent publication, which was just published in the Green Journal for Arthroscopy in January, we had 92% healing by MRI using the single row techniques with larger tears, on average 2.8 centimeters. And what we found with our single row technique is that the work score, if we healed by MRI, was at 95, where the patients who retore were at 73. And what we're not talking about here is failure and how rotator cuffs fail. And the concern that we have had all along with double row failure is you're more at risk to have a CHO type 2 failure, which can become a more concerning and devastating thing to try to fix. So one of the reasons that, you know, we're still proponents of single row, and I do single row most of the time, probably 90% plus of the time, is because our results have been quite good using what we call a SCOE row technique, triple loaded anchors just off the articular cartilage margin, minimizing tension on the repair, and microfracturing the footprint.
Mostly so on the first question is by Michael Gottschalk, who asked, how do you decide when to tension your double row, and how do you prevent medial sided failures, which are catastrophic?
Dr. McDonald or Ladner, do either you want to address that?
Go ahead, Peter.
So the question is in regards to how do you make sure that you haven't overtensioned the repair. So that's an excellent question, and I'm not sure that I really know the answer to it. I think it comes down to two factors. One is carefully assessing the configuration of the tissue, the tear, the tendons, and bringing them together in a fashion that minimizes the amount of tension on the repair, which means that if you have a deep U-shaped tear, you're not grabbing the apex of the tear and closing that down, even though technically it's possible. It makes a lot more sense to do margin convergence in those situations. So I think the first is just understanding the configuration of the tear. The second, I think, is doing appropriate releases. So that means both superficial and deep to the tendon, capsular release, interval slides if necessary. And the third, I think, is to decide beforehand what the end game is. So when I go in and I'm faced with a large or a massive tear, the goal is not necessarily to achieve 100% closure, but rather to achieve a balanced repair, meaning a subscapularis repair and infraspinatus repair. To my mind, biomechanically is the most important aspect of it. And if it's possible to complete that with a supraspinatus repair with a margin convergence or what have you, then of course we do that. Biceps SCR is something that I've incorporated as well in the last year in that situation. But I don't absolutely insist on a supraspinatus repair if I feel that the tension is over what I think is reasonable. But how do you measure tension? I don't know. I think that's just an experience thing. I think you pull on the tissue and you develop a sense for it, but I don't have any objective way to measure that.
Fantastic. Dr. Salah, do you want to give us your sense of one, do you have an algorithm for when you use double versus single row? Do you ever tie knots, or are you only knotless? And then finally, like maybe comment a little bit on the question about tension.
Sure. The first question is very back and forth between single and double row. It sort of just depends on what the cuff, tear, and tissue look like. I'll do triple row because I'll do a convergent stitch and use my most lateral one as a ripstop, put a medial anchor in, and then put a lateral anchor in. So I think the rotator cuff tends to tell you where it wants to go. So much like Peter was saying, it just varies. The second thing is there's no such thing as too much releasing to avoid tension. And if you have to pull the tendon over, then that's too much. It needs to move over. It needs to go back where it came from. But if you're having to put a lot of tension on it to pull it across, then that's a problem. The other part of it with the releases is to remember that if you have some superior migration or some narrowing of the acromiohumeral distance, you need to release the infracapsule. Because if you don't, then the head stays high, and as soon as they go to move, it pushes upward, and the thing that comes apart is your repair. And if you do a double row knotless repair and you have crisscrossing stitches, then it's going to separate, as Mark said, and you'll get a type 2 failure. So if you put two medial anchors and you have one stitch going from one medial anchor to the other, then that's going to cut across. That's also biologically unsound because blood supply for tendons comes from the medial bursa, from the medial side of the tendon. So if you cross, you're automatically preventing blood flow to the critical zone of the rotator cuff between your two rows. So whether you do a single row or a double row, you need to think about biology and a lack of tension. And if you release, as Pete McDonald and Pete Lappner said, release under the tendon, release over the tendon, always go outside the joint and release both bands of the coracohumeral ligament, the one to the subscap and the one to the supraspinatus, then you can pretty much repair every tendon without much tension. You know, De Beer talked about doing a De Beer slide. If you do that, you have to release the suprascapular nerve front and back. JP taught us about that a long time ago. But all of those releases together let you put the cuff wherever it wants to go. If you're not great at those releases, then I think Mark's technique of a single medial row for the majority of cuffs makes sense. If you're really good at all those releases, then a double row is going to have a better chance of success because it's biologically more sound as long as you respect the biology of the blood supply to the tendon.
We have a great question from Wendy Anderson, maybe from the whole panel, but she says, if you have great success with single row repairs, then why would you ever, what's your indication to do a double row repair?
Yeah, Dr. Gettleman, you want to take this?
Sure. So for me, my only indication, you know, in general is an acute traumatic tear with no tissue loss in a very young person. So if I have somebody who has a traumatic fall and they have a non-retracted, you know, basically normal tendon that has avulsed from the tuberosity and I have no tissue loss, then that's the case where I'm going to do it, because they're also going to have more robust bone off the lateral margin. Because, you know, when we microfracture the tuberosity, when we're trying to get our so-called crimson duvet to improve blood supply, as soon as you go off the edge of the tuberosity, that little microfracture all falls right in. You've got very little bone, especially when you're talking to a 70-year-old, you know, person with their rotator cuff. And so to me, again, you know, really young, somebody in their 30s or 40s who had a traumatic injury with good tissue and no tension, then to me, a double row makes sense there.
Fantastic.
Okay, awesome.
So I think this is a good transition to the next one. So Clifton, do you want to?
Yeah, happy to. Okay, so the next article we're doing is titled The Comparison of Partial versus Complete Arthroscopic Repair of Massive Rotator Cuffs with Dr. Savoy. So essentially, this was a retrospective review from a single institution over a 2-year period. Inclusion criteria required that each patient had a massive rotator cuff tear, which was defined as 30 centimeters squared or greater. Patients were categorized as either partial or complete. PROs, including the UCLA scores, were collected, and they had an average follow-up of 24 months. So they had 97 patients that were noted to have intraoperative massive tears defined by the inclusion criteria. Complete repair was achieved in 52 of them, and partial repair was achieved in 45 of them. Essentially, PROs, including UCLA scores, were essentially the same between the two groups, and they found no statistical difference between the post-op outcomes. So in conclusion, they say that partial repair of massive rotator cuffs yielded outcomes comparable with complete repair of massive tears. So my question to Dr. Savoy is, if you are able to get these great results with partial repairs in the age of augments and biologics, are you still doing partial repairs, or are you moving towards more of an augment or SCR for non-repairable massive cuffs?
Great question. So my results when I did about 36 SCRs and did not notice any difference adding the graft compared to my partial repairs. No difference at all. So for me, I've pretty much abandoned supracapsular reconstruction. I did a dermal patch. I did not do Miata's technique. So for full disclosure, which I think may be better, but for me, a dermal patch, trying to put it in with the idea that I'm holding the head down, really, biomechanically, it makes sense. But my results with doing that operation were not any better than my complete repairs or partial repairs of massive rotator cuffs. So I thought it was an added expense without any benefit that I could tell, both in patient reported outcomes, in x-ray, looking at the head staying down. I showed, I did not have a personal difference. I know others have had a difference, and I view that as really a technical issue on my part. Maybe I'm not doing it correctly, but in fact, I would say my results of SCRs were a little bit less than my complete or partial repairs for the same type of tear.
So can you expand upon that, Dr. Spalawa, and maybe give everybody a sense of, so how do you do a really well done partial repair, or maybe turn what appears to be almost irreparable into a repairable complete repair? You kind of touched on that previously, but do you mind expanding a little bit just to kind of teach us?
Yeah, so this paper actually came about with Larry and I disagreeing a little bit. Larry Field, my partner, who's a fabulous surgeon and just a wonderful guy, a good researcher, and where I basically told him that I repaired all of them, no matter what. And he liked to do partial tears. And so Nick Iagula, the guy that did the paper, the lead author, did a great job, looked at those two groups. And what we found was there was really no difference. So Larry was correct, Larry Field, in that his partial repairs did the same. And it's basically a biomechanical couple. It's the same thing that Cofield did when he did a subscap slide. It's the same thing that Burkhart brought back to us about partial repairs. So I think that when you're looking at a supraspinatus that's completely atrophied, prior operations, there's really no muscle to work with. What I would call a Goutallier grade 6. If you did 4 is more fat than muscle, a 5 is up to 75% atrophy, and a 6 is more than 75% atrophy. It's just basically a little piece of tissue. So I can put an oblique convergence stitch from a Navisor portal, Andy, credit to Tommy for that, from that portal through the supraspinatus muscle belly across to the subscap, and I can slide that muscle as far as I want. It's just not functional. So in that particular case, raising the infraspinatus and raising the subscapularis, bringing them up, gives you a very nice force couple, as very elegantly demonstrated by Steve Burkhart, and that holds the head down. That's a good way to do it. Now, if you have severe, and we'll get into this later, I think, about severe atrophy of the infraspinatus or complete subscap tear with atrophy of the subscap, then those things are not possible. So I think a good partial repair, bringing your force couple up, releasing the capsule so that you bring the head down, is a great way to keep it down and get a functional rehab. If you have a good, especially lower infraspinatus and subscapularis, then you can achieve that result.
Awesome. Thank you. And then I guess kind of transitioning, Dr. McDonald, do you want to talk about when you have a massive cuff, whether you're doing a partial or complete repair, maybe either any tips or tricks that you have? How do you get tension? How do you make sure it's tension free? You mentioned you've transitioned into knotless fixation. Are you still using knotless on these massive cuffs?
Yeah, thanks. I think that what I tell my fellows, my residents, is you really have to have patience and spend a good 30, 45 minutes doing a bursectomy and releasing all the inferior part under the cuff and the superior part over top of the cuff to get maximum mobility. I used to do interval slides. I don't do as much anymore. I tend to do as much releasing as I can, do some marginal convergence. And then it's amazing. Sometimes you look at it initially and you think, there's no way I'm going to get this repaired. And after some releasing, doing a couple of rotator or marginal convergences, the head starts to go down and you see it coming together. So you can surprise yourself on what you can repair versus just looking at it at first glance and saying, no, this is unrepairable. So I think you just have to take time. It takes experience, and you just have to learn the little tricks yourself. And Buddy mentioned also releasing the inferior capsule, which I haven't done, but that's a very good point, that once you have significant superior migration, if that acromial-humeral interval is less than 6 millimeters, I'm not that optimistic about, in my hands, with a good durable repair, but Buddy's a better technician than I am.
Yeah, Dr. Schwab, do you want to expand upon that, the releasing the inferior capsule? I think that's something maybe not everybody's sort of thought about or think about, like when do you do it, how do you do it, kind of what's your experience with it so far?
So first disclaimer is I'm not a better technician than Peter. Let's get that straight. He's a really good surgeon, and I've learned a ton from him over the years, going back all the way to our time in London. So I think that the key to remember about a massive cuff is that there are chronic changes. And so you would think, well, it's a big cuff, so the shoulder's really loose and it goes all over the place. But in fact, it's usually tight. It's not loose. People have been holding it together to their side the entire time. So one of the things that happens is the inferior capsule will contract and get tight. So it's not the unopposed vector pull of the deltoid that's always narrowing that acromial-humeral distance. It's the scarring in the inferior capsule, and it's an adaptation to the fact that you have a chronic tear. So if we're trying to get them back to normal, then we have to release all the capsule. And I actually started learning about capsular releases from Evan Flatel. I know he's here. He was talking about what Dr. Neer did open to repair rotator cuffs open a long time ago. I think, and I don't want to misquote him, but I think Evan called an irreparable cuff sort of like an unrunnable marathon. You can always do it. You can always get it back. It's a question of why. So part of that deal is if you're trying to balance the ball on the socket and it's sitting high, you're not going to be able to pull it up and over. Think of a boutonniere deformity in the finger. You're not going to do that back. But if you bring the lateral bands up, you can pull it back down and you can repair it. It's the same thing in the shoulder. It's not coming down if there's an inferior contracture, so you have to release it. So what I do, I go in, I look at the cuff, I start in the front, and if there's any subscap involvement, I will release the anterior capsule down to about 4 o'clock. I'll come up over the top from the coracoid. If we have anybody from France, my apologies, but I'll leave the biceps. I'll use it later if I need to as a graft. I learned that from Andy's dad. You come over the top and you release all of the supraspinatus, come around the back, release the posterior capsule, and then I'll release the posterior capsule from my posterior portal using a hook cautery all the way across, and then I'll check my motion. I don't manipulate first, but I'll do all of that and I'll check my motion. And if I'm beach chair, we pull down on the head and we should see it come down. If it's lateral decubitus, we just kind of pull on the arm a little bit and let the weights pull the arm into traction and it pulls the head down. And it's amazing, as Pete said, when you finish all these releases and you look at it and you pull the head down a little bit, the rotator cuff just kind of comes back over the top and you go, well, hell, I can fix that because it's much easier. But it's the 30, 45 minutes, an hour that you spend prepping it before you do 15 minutes of rotator cuff repair. But that's what lets you get it all back.
Fantastic.
I have a question from Carlos Guzman, who wants to know, with a massive rotator cuff, is releasing the suprascapular nerve a must?
Not a must. It's never a must. So it depends on, well, I should open that up to everybody. Sorry, I didn't mean to jump in. But to me, it's not a must. I think it's helpful. We wrote another paper a few years later where we looked at our grade 4 atrophy and worse, that we always did a suprascapular nerve release on, supraspinatus and infraspinatus, and then our grade 3 atrophies. And what we found was we gained an extra grade of strength by releasing the suprascapular nerve. Now, maybe that was, traumatic inhibition. It can be other issues, but I do think it makes a difference for massive cuffs. If you don't have traction on the nerve, it decreases a little bit of pain. And to get over there, you're doing an anterior interval slide anyway, just like Joe Toro talked about. So you get over there, you get to the nerve. It's pretty simple to release it because the anterior anatomy is very consistent. There's a few rarities where it changes, but in general, it's pretty consistent. So it doesn't add a lot of time to the case, I think, for most people. I do think it makes a difference in a select group of massive rotator cuff tears. So you don't always have to do it. But if you're sliding that tendon a long way, or they've had previous surgery and someone's kind of messed around a little bit with the medial side of the rotator interval, then you may need to look at that.
Wonderful. Dr. Gettleman, do you ever release the suprascapular nerve, or what's your indication for that? And then also maybe follow that up with, if you don't mind, what's your how your approach changes from a big, massive retracted cuff tear versus the one you discussed previously?
Sure. So, I do release the suprascapular nerve, and for me, it's kind of a gestalt thing too, where if the patient seems like they have more pain that's kind of out of proportion to what I'm looking at, then I'm looking at it as a potential pain generator as well, and I'll release that nerve. There are times when you look at the tear and it may be retracted to you know, the level of the superior aspect of the humeral head, and they're starting to develop atrophy of the supra and the infra. And in those cases, I tend to release the nerve all the time. Because again, as Buddy just said, if I'm pulling on that cuff, pulling it out more laterally, and they already have pain and they're starting to develop atrophy, to me, that makes sense. If I have the massive ones that are already like Coutelier 3s and beyond, I don't know how much it's really helping. And so I used to do it more aggressively. Now I've kind of cut back on those, and I tend to do that less. I think the key points that both Peter and Buddy made is you got to do your releases and you got to spend time. And, you know, what I'm always talking to the fellows about is they look inside and they see this massive hole and they like panic and they're like, oh my God, I got this huge hole. Now what am I going to do? And I think it's the exact opposite. You got to take a step back. You got to start mobilizing your tissues, do your releases. Any subscap damage for me in a big tear, I fix. And a lot of people kind of go, oh, I got all this work to do on the supra and the infra, and they ignore that subscap. And I think probably the most important anchor I put in on that whole case is that leading edge of the subscap to start getting that force couple reestablished that Buddy talked about. And if I can get the subscap reattached, any subscap, even if it's small, I'm going to repair, and I'm going to try to advance that subscap so I can get that force couple back to the infraspinatus. I do that oblique margin convergence that Buddy talked about. But I find once I'm starting to do significant margin convergence, those are the ones that fail. And even if I do an inferior release, that head tends to put pressure on that. And those are the ones that I find end up being recurrent tears. And in those cases, I have a short fuse to do a dermal allograft augmentation. And, you know, the work that we did with Joe Burns, you know, one of my former partners, and Alan Barber, looking at doing matrix allograft augmentation on the bursal side, where I have that margin convergence, then I got the tendon back, I'll then put a bursal-sided dermal allograft on top of those to try to take some of the tension off the repair and help with healing. So that's kind of been my go-to on those bigger tears. You know, my results were not great with my partial repair. And for me, adding a dermal graft seems to have improved our outcomes. And we're still in the process of kind of looking at those numbers right now. But for me, I have a short fuse to add a dermal graft on the bursal side if I can augment.
That's wonderful. And you're, just to clarify, this is a dermal augmentation graft. This is not like an SCR, correct?
Well, yeah, I mean, I'm using dermal allograft, but on the bursal surface, not fixing it to the glenoid. If I can repair the cuff. If I have a massive cuff that I can't get repaired, then we're still doing primarily off-label, you know, bridging repairs with our graft. And I did a comparative thing where I was looking, and my numbers weren't big enough to publish, but with SCR versus doing, you know, interposition, and my outcomes are better with interposition than with a true SCR.
Wonderful. Anybody else want to talk about when they do employ one of these other techniques, whether it's an SCR, an interposition, or augmentation graft, or arthroscopic tendon transfer, and sort of how they make that decision, whether it's pre-operative or intraoperative? Advisor?
I would say for me, if I see superior migration of the head on an X-ray, I don't think that a cuff repair is going to be a viable option. Aside from an acute traumatic tear and a traumatic change in their function. But if you're dealing with somebody who has chronic dysfunction, for me, I'm thinking of doing some other salvage procedure depending on age, tendon transfer, reverse, maybe a SCR. But I will usually would stay away from a repair in that scenario.
Wonderful. Wonderful. Anybody else? Perfect. So let's move on to the next one. So the next one's going to be Dr. Jane and Higgins' article on comparing operative versus non-operative treatment of rotator cuff tears. So this is a multi-center, non-randomized cohort comparing the op versus non-op treatments. 127 patients ultimately included, 50 operative and 77 non-operative across 4 centers. It should be noted that both partial and full thickness cuff tears were included. They did do a propensity score analysis showing very similar demographics between the groups. It should be noted there's more partial thickness tears in the non-op group. So when looking at the outcomes from 6 to 18 per month, it did appear that the opera group had higher clinical outcomes, including the SPADE score as well as the ASES. Table 4 and 5 kind of demonstrates the sort of higher percentage of people achieving both greater than 30% improvement or greater than 50% improvement in the operative groups. And figure 1 does a really nice job showing kind of the recovery curves between the two groups. You can kind of get a sense that overall the operative had a higher propensity score adjusted difference when comparing the two groups. So overall, this is a really provocative study. Contributed to the debate on operative versus non-operative management of rotator cuff. There's been a lot of literature on this, and there's been a lot of focus on it in recent years, including some really nice NIH studies. You know, we're still difficult to tell with this study. Is it that really operative is improving these outcomes and challenging some of the other studies, or is this is it too soon to tell with some of these tears, given that we're relatively short-term follow-up, or is this really kind of showing us a new approach that maybe contradicts some of the other ones like Kukkonen and Hirschbrink and some of the other randomized controls trials out there? So, Dr. Jain, as a lead author, do you want to discuss with us sort of how a surgeon should incorporate the findings of this study into and incorporate with some of the prior prospective studies that are already out there on these atraumatic rotator cuff tears, and maybe help us to solve some of the controversy between the studies and how we should interpret the results?
Sure. Thanks for having me. Just out of full disclosure, I'm not a surgeon, so I can't talk about technical issues, but I am a physiatrist and have worked and trained with some of the surgeons who have pretty much taught me about the shoulder. And, you know, the impetus for this study was the uncertainty that exists in the literature about operative versus non-operative treatment. All of you are familiar with the SPORT trial in the lower back, as well as some of the trials that were published in the New England Journal back in 14 and 13 on knee arthroscopy. And so that's kind of really what, you know, inspired us to start this study. As you all are aware, there are 3 studies. One is the Moosmeier trial that showed that there was a difference between the 2 groups at 1-year follow-up, but then that difference did not exist in their long-term follow-up, I believe at 2 and 5 years. There was also the Kukkonen study where they actually had 3 groups, physical therapy and acromioplasty, and then cuff repair and acromioplasty. And they really reported no difference in the constant scores at 12 months. And I believe there was another recent study, which is the Lambert study, I believe. Yes, Lambert study that had 56 patients. And at 12 months, they had no difference between the 2 groups. So essentially, as you all know, this is so if we really put this into context, I think I'm preaching to the choir here, but we do about 500,000 cuff repairs in the US every year on an average. This number is likely grown. We probably have about 5 to 10 times as many patients going to physical therapy for rotator cuff issues. So this is a big issue, and our healthcare system, I believe that the treatment of cuff tears accounts for one of the top 10 reasons that Medicare makes payments. So I think arthroplasty is one of them, and then really from an ambulatory surgery standpoint, it's very likely that cuff repairs and shoulder arthroscopy has actually surpassed knee arthroscopy if you look at the numbers. So this really is a big issue that's been brought up by the Agency for Healthcare Research and Quality, by the American Academy of Orthopedic Surgeons. I mean, all of the governmental agencies have a lot of interest in this. You know, we're doing a lot of this. Does this really work? And so I think where the previous literature leaves us is it's really uncertain. And there were a number of I mean, these trials were well done, quite frankly, but there were a number of methodology issues with these trials, which make the results uninterpretable. I'd say the best attempt at answering this question was done by Andy Carr. So Andy Carr, as you all know, is a British surgeon who tried to conduct a randomized control trial of over 50 centers in the UK. And that trial essentially failed because I think one was the nationalized healthcare system in the UK, which sort of mandated certain patient pathways, as well as the patients kind of just did not follow the regimens. A lot of them crossed over. So they eventually had to publish a white paper, but that trial never got completed. And that's the background to this study. So I would say this is a non-randomized study. So there's some strengths to this study, mostly from a methodology standpoint. But there's a number of limitations, and primarily this is a non-randomized study. So there's an inherent bias in who gets surgery versus who gets physical therapy. The biggest contributor to this patient is Dr. Higgins, who is here, but then there were, we recruited these patients from 4 different centers, including a rural center out in South Dakota. But you know, there is a bias towards, I would say maybe about half of the patients coming from Dr. Higgins. And what we are seeing here is, if you look at the figure, again, just so that we are clear, is in general, ASES scores, the higher the scores, the better the outcome. In our graph, we actually inverted to just match it with the SPADI scores. And so the lower the score, the better the outcomes. And our operative patients get pretty close to 100%. Their SPADI, their ASES scores, as well as SPADI scores at 18 months is 5.4 and 7.4. That's as close you can get to 0 on a scale of 0 to 100. Whereas our physical therapy patients only get to a score of about 25. So there's clearly both a clinical, it crosses the MCID. So the MCID for these scales is about 10 to 15 points or 20 points, depending on what you look at. We pretty much cross all of those MCIDs. So there is a significant difference. But I would just say that we can't really make a judgment based on, I mean, this is not a randomized control trial.
Yeah, of course. No, thank you. And thanks for that thorough summary. Dr. Higgins, as do you want to give us your sense on both from this as well as kind of what's your algorithm for approaching atraumatic rotator cuff tears? How do you sort of make a cost-effective approach, as you're sort of one of our experts in approaching many of different cost-effective topics, including this one?
Great. Thanks, Eric, and thanks for giving us an opportunity to present our data. I think what was unique about this study, and I owe a lot of this to the methodology that Nitin created, was the fact that we started looking at the people that actually had substantial improvements, you know, the people that scored greater than 30 or 50% improvements. And it was clear from the data that we actually had this great propensity for people who had an operative treatment to actually far exceed the ability of the non-operative treatment. And I think we saw that clinically. And while, you know, everyone participates in randomized clinical trials, and I certainly have done that, this was a group of patients that we treated with, you know, our best judgment. And so this was a select group of patients that I thought that we could make better surgically. And there were certain people that, you know, there's a little more nuance when you're actually treating them and they're not getting fit into a study and you're trying to get them to fit into a study. I think all of us who participate in randomized clinical trials have enrolled patients in the study and then secretly hoped that they would actually end up in one arm or the other arm. And Buddy's shaking his head yes, because he knows exactly what I'm talking about. And you've had this buyer's remorse, for lack of a better term, about enrolling a patient in a study, and then you're kind of keeping your fingers crossed on where they're going to land. But this was a little bit more of a pure group. And so this was the group of patients that I and 3 of my colleagues thought would be best treated surgically. And I think it just underscores the fact that PROMs and VAS scores don't tell the whole story. There's still some art here, and there's still some ability for us to look at the patient more holistically in ways that it's hard to just quantify with numbers and say, yeah, I think if you're going to treat them, they are going to do better than the non-operative cases, because this is a group of people that you select for that purpose. So the algorithm for us is to follow up in the last part of the question is, you know, there's a lot of shared decision making with the patient, and we present data like this to them and tell them, I think that, you know, you'd be a great candidate for surgery, and if you have a successful outcome, and we saw the double row work that Peter and presented earlier, but with the higher, you know, healing rate, you know, I'm a fan of double row repairs. When I take them to the OR, I do all the things that everyone talked about. We won't repeat them, the mobilization. And then we do everything to get their tendon to heal, because it enhances strength and decreases failure rates. But there's more nuance here than it is in just a clinical prospective randomized clinical trial. And I think that's an important thing that we're pointing out here.
That's fantastic. All right, Dr. Swal, I'm going to put you on the spot a little bit as both a surgeon and as in your other hat as our leader of the academy. Can you talk to us, you know, about this sort of important topic, important implications? You know, when should we, how should we approach these atraumatic full thickness tears? From kind of talk, can you speak to us from both of your hats standpoint and kind of help us to, as young surgeons or residence fellows, understand how to think about Dr. Higgins and Jane's really intriguing data?
I think the most simple thing, if I can put the non-academy hat on, would be if you come in with an atraumatic cuff and you've suddenly become symptomatic or you've gradually become symptomatic, why not try a cortisone shot, put them on physical therapy, give them a month and bring them back. So then the patient makes their decision. Something made them hurt. Could have been, they just slept on it funny. They did anything. All you're trying to do is bring them back to their base level function where they've been for the last 10 years. Andy talked about, their chronic changes, and I can't make that a whole lot better. I mean, you can, depending on what you're dealing with. So the most simple thing, if you're considering non-operative treatment, so you have your category, you have an atraumatic cuff that became symptomatic without a trauma, so it's not an acute on chronic, then try to bring them back to baseline. So, I mean, older surgeons, and I'm in that category, use cortisone shots all the time. So put a shot in, put them on a little therapy, do it for a month. Don't waste a lot of resources. They either get better or they don't. If they don't, then you need to consider whatever option you think fits in. And that's a nice way to use what Larry said, which is the art of medicine. All of a sudden you're treating the patient and trying to get them better. Now, the flip side that Dr. Jane talked about was rotator cuff repairs are moving up the ladder for CMS. So it's been hip and knees, and that's an easy target. Rotator cuff tears are not. So the Academy has put a registry together, just like they did for the hip and knee, but now we have a rotator cuff registry. So we're tracking a lot of data. The problem is that data is all surgical. So you're not actually collecting non-surgical data, and the vast majority of rotator cuffs are treated non-operatively. So by definition, the ones that we're getting have theoretically become symptomatic. I mean, people are not walking in your office and saying, I have no pain in my shoulder, but I had an MRI that showed a cuff tear. I want this big operation so I can hurt for a year. Nobody's going to do that, right? So what we need to do is have data to show there's a value that in a symptomatic patient that you fix. And Moosemeyer has a 10-year follow-up now showing very good results on his repairs. Very good results. It's actually on the longitudinal study for board certification, that article is. So I would encourage you guys to look at it because it's a very good article, and maybe we need to change a little bit of our CPG process and some of the things that the Academy has about rotator cuffs, because the evidence is weighing more towards a symptomatic, painful rotator cuff, even if atraumatic. Something has now made it significant, and if non-operative treatment fails, then that should lead you to a successful result.
We have a question on those lines from Joseph Lamblot. It says, can you discuss your approach to the use of cortisone in potentially repairable operative cuff tears?
That goes back to me.
Yeah, Dr. Spy, if you want to, I think what he's getting at is do you think it's going to affect your ultimate healing rates once you decide, if you do decide to repair?
I like to, I think Pete McDonald can do that as well. But basically for me, if you're symptomatic and I'm considering surgery, then I'm not going to do that. So, and if I do, there's a distance between. Now, if I have a very stiff, inflamed shoulder, I don't have any problem putting a cortisone shot in, putting them in therapy for 6 to 8 weeks. The studies vary on the effect of cortisone on decreasing your healing rate and increasing your infection rate, but it's pretty much gone by 3 months after the shot. So, but if I'm contemplating a surgery in the next month, then I'm probably not going to put a shot in. If I'm thinking I'm going to get 3 months or so, or if I have a significant amount of inflammation, then I might do that to get rid of that inflammation, increase my passive motion, so I don't have to do as much when I go in. I don't think that's as big a problem. But Peter's smarter than I am, and listen to him.
Yeah, Dr. McDonald, do you want to give us your 2 cents from north of the border and how you approach this, and are there any other factors that you consider, maybe age or some other things in making the decision to operate versus continue with therapy?
Yeah, this is a great discussion, and I think one of the most interesting things in shoulder surgery is why some cuff tears hurt and why some don't, and why some people compensate so well, why other people don't. So I think it's a really interesting topic. Obviously, if 40% of 70-year-olds have a rotator cuff tear, we're not fixing 40% of the population. So there's a lot of people out there doing fine, thank you very much, with a cuff tear. So this is one time where it might be an advantage to live in Canada, because from a healthcare point of view, because our patients, by the time they see us, they're kind of weeded out. They've self-declared themselves. They've been through physiotherapy. So in my practice, they've already been through all the non-operative measures. So the ones that see me usually are the ones that have failed non-operative. But in a general sense, a traumatic tear, I'll be more aggressive about getting them in early. Atraumatic tears, if they're young and healthy, I'm saying like less than 60 years old, then I'd be more aggressive about doing surgery rather than a prolonged period of non-operative treatment. Between 60 and 70, then I would probably try at least 3 months of non-operative corticosteroid injection just to calm things down and send them to a good physiotherapist. And there's physio and there's physio, so you have to make sure it's a good physiotherapist who's really familiar with rotator cuff work. And then over age 70, despite the fact there are some studies showing you can have successful cuff repairs over age 70, I would tend to be a little more conservative in that group.
A great follow-up. Catherine Fedorka asks, maybe just go down the panel. She wants to know, is there an age where you essentially will try to forego non-operative treatment and go straight to operative treatment for a rotator cuff tear?
Dr. Gaiman, do you want to start us off?
Sure. I mean, I don't think there's necessarily a set age. For me, it's what is their function, what is their job, what caused the inciting event. Certainly, if they had a traumatic event and they're still working and they're a HVAC installer and they're doing above work their head all the time, I'm going to fix that traumatic rotator cuff early on, and I'm not going to spend a lot of time on non-operative measures. If they have an atraumatic tear that has certainly decompensated, then I agree with Buddy in terms of trying non-op originally, and I am less aggressive with cortisone. I tend to start them on an anti-inflammatory and try PT and see them back in 4 to 6 weeks. If they're getting better, then I may offer that cortisone shot thinking that we're heading down the non-op route that looks like it's going to go longer down the line. But what I don't like to do is give them a cortisone shot and then they come back and they're like, well, I really want to have surgery. I'm like, well, no, we can't. We've got to wait for the risk of infection to decrease and all this stuff. So that's kind of my approach. If they're still working, I tend to be more aggressive. If you have a 70-year-old, then I'm certainly going to try everything I can on a non-op approach first and foremost until we get to the point where they can't do it. Now, that changes. We're going to talk about that in the next paper. But if they have subscap involvement and they're, pseudoparetic and they can't lift their arm, you can do non-op until the cows come home. And I don't think we're going to make that patient better.
Wonderful. Dr. Flater, an advisor, before we go on to your article, do you anything that you want to add to your decision-making with regard to age or anything else?
Well, I think it was well discussed. The factors that impair healing is, the size of the tear, the chronicity, age over 60, muscle atrophy. And I usually, not being in Canada, but in New York, where you get an MRI with a tank of gas and every patient gets 6 opinions, I usually discuss the data with the patient. Even if the data is 90% re-tear, well, 1 in 10 is a good shot for some guys, they got the cash, they got the time, and they want to give it a shot. So I usually have a discussion. I think if the patient wants strength, they're not just interested in pain relief, but their goal is strength, and they have muscle that's still there because our data with recovering from atrophy is not very good. And they, and the tear is such, they don't have, as Dr. Neviser pointed out, superior ascent and fixed pseudoparalysis, et cetera. I'll consider a repair, but I usually have a discussion with them along those lines. Obviously, I do what everyone else said. The older they are, the worse the muscle, the more likely I am to do non-operative. I think the real case for a repair is a fresh tear that has that wavy pattern of the tendon, a bunched up muscle at any age. I think it's worth trying to put that back.
Wonderful. Awesome.
The only thing I think I could add to the discussion is I make it a point of trying to tell the patient what we mean when we say the chronicity of this tear. If we're really talking about atraumatic tears, this is a tear that may have been there and been gradually growing larger over years to maybe decades. little bits of micro damage that build up, that start as a partial thickness tear, that ultimately lead to a full thickness tear. So if you can help the patient to understand that this is a very long-term, potentially a long-term problem, they're less afraid to leave it alone for 6, 8, 12 weeks of physical therapy. But if you tell them their tendon's torn and their eyes bug out and they demand that they want it fixed, don't bother sending that patient to physical therapy because it isn't going to work. They don't believe in it. And there's very compelling evidence from the Moon Group that they won't be successful with that and they should get surgery. And that's the right answer for them. But, and I know this was, Dr. Flater practices in a very different environment than say I do now in the Midwest. The people in New York want it fixed right now. And that's not as common the case in what I see. And I think helping them understand this is a biologic problem. We are continuing as surgeons to talk about mechanical solutions to this, but ultimately it's a biologic problem. And we don't even know necessarily that when we fix them and they heal, that that's going to protect them from the long-term consequences of what this may be. So I think that's an important point to make to your patients.
Fantastic, thank you. Let's move on to the last one. So Clifton, do you want to take it?
Yeah, so I'll be brief with the summary because this discussion has been so awesome. Okay, so this was a title article, the retrospect review of open and arthroscopic repair of anterior superior rotator cuff tears with subscapularis involvement, a single surgeon's experience. So essentially this paper was a retrospective review of 57 rotator cuff repairs involving the subscapularis performed by a single surgeon over 10 years. During this time, the surgeon transitioned from open to arthroscopic repairs. They collected most of the standard PROs that we're used to. They essentially found that the preoperative and postoperative PROs were pretty symmetrical between the two groups. And they found that there was no significant difference between the scores between the two groups. There was only one notable complication, which was a superficial wound dehiscence in the open group. So this study concluded that there was no outcome differences between open and arthroscopic repairs involving the subscapularis, even with large subscapularis tears. And they said that both techniques significantly improve function. So for Dr. Flato and the panel, what is your algorithm for treating subscapularis tears? When do you do an open and when do you do an arthroscopic? What characteristics lead you one way or the other?
Well, we do them all arthroscopically now, with the exception of some revisions, perhaps, or other rare situations. This was my learning curve. I was very influenced by Laurent Lafosse and Steve Burkhart in doing this. And, but we were nervous because we were doing this at the time. A lot of reports said that arthroscopy had higher failure rates and everything. And this is a tricky area. So many of these tears were sitting right on the axillary nerve, and you had to really know where it was and dissect it off. It's swelling is an issue if you're not careful. But in the end, we were quite reassured with these results. But I'll let Andy, talk a little bit more about the nature, of the data.
I would echo what you said. I think it's also important for current fellows to know that open rotator cuff repairs did pretty darn well. And that we've made advances in arthroscopy and we have reduced the complication rate, but the overall functional outcomes and things are not dramatically better with arthroscopic. And I think this was one of those things where I don't think people saw the potential benefit of doing a subscap arthroscopically because you didn't really have to take down any of the deltoid to get there, and the approach was less morbid. And so I think that's part of the reason that it's slower to catch on, that and the axillary nerve. And going through these charts, and again, I did this when I was a fellow, which was 2011. So this, although it came out much later, this is data that's and patients that you treated quite a while ago. They all did very, very well. And I think it echoes that this is a procedure that should be done arthroscopically, because why not? particularly if you have other tendons torn. There's no reason to open the shoulder to do it. You can do it just as well through the scope. And B, in reality, the mechanical exercise of doing the repair is probably less important than things like Larry talked about, selecting the patient that you're going to do it on. And I don't think we should forget that, that ultimately what we need to figure out is who benefits best from surgery and who would be perfectly fine with physical therapy. And I know Nitin is actively studying that. And ultimately, the way we do the surgical repair is less important than we'd like to think it is.
Wonderful. Kind of going on that that topic. So with the arthroscopic technique, Dr. Advisor or Dr. Flato, whoever wants to contribute, can you teach us a little bit about what are the important technical pearls and getting a good subscap repair? Maybe a technical tip or two on certain things that you teach your fellows and residents, and how we can be sure when we do it arthroscopically that we're doing it in as a successful fashion as was demonstrated in this article.
Well, I'll take a stab. We use low pump pressure. I learned that from Mike Hausman, who doesn't like elbows to get swollen because of the nerves. We used to really want a lot of pressure, but if you're quick at finding bleeders, and we don't pour buckets of water in open surgery for bleeders, we just find the bleeders. So low pump pressure, doing the subscap early if you have a multi-tendon tear, because it's a little problem if it gets swollen in the front. I think if the supra and subscap are off together, we leave the comma as described by Steve, because then it's like pulling a turtleneck over your head. When you get over the horizon, they hold each other on, and it's useful. If only one of them is torn, we divide the interval so that we're not being held medial by the intact tendon. We find if the whole subscap is involved, we find the subscap. I think it's healthy for a surgeon, especially a specialist who wants to, be a leader, to sort of become hyper-focused on one technique at a certain time in your career. Like sometimes you get my fellows notice I'll get sort of obsessed with one thing or another at, 1 year or another, because you really want to play it out. And we even got to the point of learning how to pace the axillary nerve with a blunt shielded block needle that we put to a quantitative nerve stimulator. So you could actually find the nerve and pace it and know where it was. And, and so that helps you. In a routine case, you don't need it. But if you're doing a revision where it's really socked in, Brad Parsons and I did a previous failed instability repair where the nerve was stuck in the subscap. We were able to arthroscopically dissect it out. So I think a healthy respect for the nerve and avoiding the subscapular nerves that will denervate it. And then finally, I think it's important to have a Krakow stitch or some kind of grabbing stitch in the superior rolled edge, because it's like a bunch of spaghetti. Any other suture, it'll just pull in continuity. And then I think the most important thing is to recognize you have a subscap tear. Before Gerber taught us about lift off and stomach press and all that, we missed them all over the place, right? We weren't doing arthroscopy. We didn't have MRI. I mean, I trained with Dr. Neer, and he was a brilliant guy, but we didn't see a whole lot of subscap tears, and I know they saw us. So I think just knowing it's there, I can't tell you how many people I've seen that have had a small anterior supra tear fixed and the subscap left off. Then they come to me because it didn't do well. So if you know it's there and you know what to do, you're way ahead of the game. Andy, what else could we cover?
Well, everything I have to say about this, as well as any other topic, I learned from you. So I'll regurgitate some things you taught me. And I think that's the first time you dissect out the axillary nerve, it's nerve-wracking, no pun intended. But once you get used to doing that, and you recognize it has a fairly predictable position, I think that it's nicer for the patient. It's easier on the staff just to do this arthroscopically. And is the principles that we have for posterior, superior cuff tears are the same as anterior cuff tears. Do your releases, get a nice mobile tendon, do a repair that isn't under great tension. It can be single row, it can be double row. But as long as it's reduced relatively anatomically and not over tension, they do very, very well. I actually think when you address the subscap, a lot of those patients do better than larger superior posterior tears.
Also, it's a humbling thing with subscaps because we have an actual test for that exact muscle, right? You can fix a supraspinatus and it re-tears. You'd never know it retore if you didn't get an MRI in half the cases. When the subscap doesn't work, you know it, right? And I think, you know, in this, we only converted about 55 or 60, I forget the exact number, about 50 to 60% of the pre-op positive stomach presses were converted to negative, but that's a lot, right? I mean, none of them would have happened if you didn't do it. But you don't even need this. I mean, it's nice to get the imaging study, but you don't need it necessarily because it's a pretty easy muscle to test on exam.
Awesome. Dr. McDonald, going back to your single versus double row, do you have a preferred technique for your big subscap tears when you fix them? And are you a believer in double row as well over the lesser tuberosity, similar to how you do your posterior superior cuffs?
Yeah, like Evan and Andy, I'm becoming I have more respect for the subscap than I used to, based on when I started practice. So yeah, it's a very important muscle to fix. You place a high priority on it. To answer your question, I think the superior 1/3 tears, if they're part of supraspinatus, as Evan said, you can kind of fix them all as one. But if it's a complete tear greater than 50%, or a high grade or almost complete insertion of subscap, then I would try and do a double row. And you can do that once you get used to it quite easily through the scope. With a 70-degree scope does help with that.
Wonderful. And Dr. Gettleman, can you talk to us about when you have a subscap plus a supra, maybe some tips on how you approach that, preserving the comma sign, et cetera?
Yeah, so, I think those are different animals than, the isolated, as Dr. Flato talked about. And if the comma sign is intact, I think it's an important landmark to keep in position so that you can really get your anatomy restored anatomically. And, when you're coming into the joint, even when you're first starting for the fellows, if the comma sign is medial and you come in lateral to the comma sign, then you're not going to be able to get appropriate tissue reduction. So I always bring my rotator interval portal in inferior to the comma sign. So I'm kind of elevating my comma sign into an anatomic position, which kind of starts my reduction of both my supra and my subscap to begin with. I think getting a traction stitch in the leading edge of the subscap to kind of know where that needs to go is important. And if it's a relatively small involved subscap at that point, then I will fix the subscap first intra-articularly. If it's a big anterior superior tear that involves 50% of the subscap as well, then I'll do my articular sided releases, and then I'll quickly get to the subacromial space, and I will fix both the subscap and the supra from the subacromial view up on top. And I find that that's a little bit easier kind of to maintain that sleeve of tissue. And then the question is, obviously, what are you doing with your biceps? And, if their biceps is involved, I think, release your biceps early to get it out of your way. It makes your visualization easier. I do them in the lateral position. It's definitely easier if the biceps is out of your way, if you're going to have to try to do that leading edge subscap. But again, if the subscap is intact and the transverse humeral ligament is normal, I don't always take the biceps. I'll leave the biceps because I think it's helping to keep the stress off the repair as well. So I think, there's lots of different ways to skin a cat, and you just want to make sure you have appropriate fixation, again, without tension for that repair.
I think Mark's point is very important about the traction stitch. I like to take traction sutures and then take a spinal needle going over exactly where I want to repair the tendon, like right past the lesser, and then a tiny nick and then a retriever and pull it out. So when you pull on the traction stitch, it's pulling your tendon exactly where you want it to go, not this way, not that way. And that helps you see it. And sometimes with a tooth tendon tear, we'll have a couple of them, and they all just go through little punctures, and that can really help. And then the other point I think Mark made that's really important is subscap, a small one, can be fixed from the inside. It gets a little, tricky, But when you get bigger, you're coming from the outside after your releases, and the anterolateral portal is nice to look right down the subscap, medial to the plexus if you have to, or inside the joint, and then you have a little anterior anterolateral portal, so that you have your two normal portals, but you add that anterolateral portal, and that gives you flexibility, to go back and forth, just like you might add a posterolateral portal for an infraspinatus for a posterior superior tear. And with practice, it gets easier than you think.
Wonderful. Awesome. So before we conclude, Dr. Swag, can you just give us the tips on the really massive subscap that's retracted? How do you successfully get it back tension free, and any tips you can add in addition to what Dr. Flavo, Gettleman, and McDonald have already discussed?
So one really simple thing is if it's a retracted subscap, you always want to release your middle glenohumeral ligament. So, because that's what limits your external rotation at your side. So one of the things when you repair a subscapularis and people get stiff, I mean, Evan talked about how you can always tell when they come in. So if you fixed a subscap and they come in and their external rotation at their side is 90 degrees, you're probably not intact. And so I think if you're doing it, I usually do mine from the inside because I have an easier time seeing the axillary nerve, whether you use a 70 or not. And then you can use a traction stitch or a grasper to pull it laterally as far as you want. But I think releasing that undersurface along the scapula is helpful. George Athwal has a great technique for looking from the outside, just like Evan described. And I think he has a video somewhere, but if you look at it, he looks from the outside, he does all the tricks that Evan talked about, and it's a beautiful way to fix a subscap double row and all the simple things. I'm like everybody. I started off with, I had a retracted subscap. I did it open so I could find out where everything was. Because, at one point you're sliding down the scapula, you're going to be close to the ribs. You're looking for the posterior cord and the radial nerve and the axillary nerve, and you have to find all that. Now, with arthroscopy, it's easy to see, kind of hold them out of the way, and you can pull everything back. So I think the biggest thing is don't be scared of it. But remember, when you're going towards the bottom, there are very major things there that you don't want to cut. And Andy talked about it, that the first couple of times you do it, it's kind of scary, and you see the nerve, and then once you get used to it, it's just there. It's there. It's normal. It's going to be there. Don't put a stitch through it, and then you can pull everything back. So that's pretty much it. I think subscaps have good blood supply. They tend to atrophy less, with chronic tears. So it's a really good one to fix. And if you have a big tear, you can shift it superiorly a little bit, like Dr. Cofield taught us, and really get a good biomechanical force couple. I also agree with Mark that I don't always just cut the biceps, and I actually don't much care about the comma sign at all. I think I know where the upper subscap is, and if you know how to find it, that's not a big deal. But if it's a guide and it helps you find it, I don't have any problem using it as a guide.
Wonderful. Well, thank you everyone so much for joining us. And thank you all the panelists. You guys are incredible. Love the discussion. This will be recorded. This will be published online. So anybody who missed it or missed parts of it, please feel free to go back and look at it. And sorry we ran over a bit, but I really appreciate everybody's incredible insight into this. And thank you all the authors for joining us. So Clifton, do you have anything to add?
No, I learned so much, and it's truly an honor to be on this virtual journal club with everyone. I just want to thank the panelists and Eric. Awesome job organizing this entire thing. As per usual, you did all the big work, and we're all grateful for it.
Well, thanks, Eric.
Thank you.
Great job, guys.
Great
Thanks,
job.
Eric. Thanks, guys.
Appreciate being
Good
on
job,
part of it.
guys. Thank you.
Good night.